Our next section is septic arthritis. This is very important because septic arthritis is a very inflammatory disease, and the diagnosis has to be made. If you miss the diagnosis, the patient gets erosion of the joint and is disabled for life after that. So let's look at this case. A 67-year-old woman with history of rheumatoid arthritis presents with new onset right shoulder pain and swelling for 2 days. She has low-grade fever and decreased passive and active range of motion of the right shoulder, as well as erythema. She asks you if she should restart her steroids to decrease the pain and inflammation. So look at this. They give you a patient with already pre-existing rheumatoid arthritis, but look at here, they only give you right shoulder pain and swelling for 2 days. Now, this is, if a patient has a rheumatoid arthritis flare, they present with a typical rheumatoid arthritis, which is polyarticular symmetrical involvement, not monoarticular disease. She also has another thing that's very characteristic of septic joint, and this is the decreased passive and active range of motion. That's typical of septic arthritis. And of course, the next appropriate step in this case is to do a joint aspiration, and what you're going to find in the joint aspiration in this case is white cell count of over 50,000. Remember, that is diagnostic for septic arthritis. Anything over 50,000 is diagnostic of septic arthritis. Even if you don't find the organism, which you don't find most of the time, you have to treat for septic arthritis. Now this case, because the woman is older, the most common scenario, the most common organism that causes septic arthritis in this woman is staph or gram-negative. Now, if you take all septic arthritis across the board, the most common cause of septic arthritis is gonococcal arthritis, but this more commonly occurs in young people that are sexually active. Older patients, especially in people that have pre-existing joint disease, like the patient with rheumatoid arthritis, they get septic arthritis usually from staph or some kind of gram-negative like E. coli. So please be aware of that. It's characteristic that a lot of the patients, the older patients that get septic arthritis, they have pre-existing joint involvement, either from rheumatoid arthritis or osteoarthritis. It seems that the osteoarthritis or rheumatoid arthritis destroys the protective mechanism the protective mechanisms in the joint, and then when you get a transient bacteremia, now the joint, you get a seeding of the joint and septic arthritis. So septic arthritis, we always need to consider septic arthritis in people with monoarthritis. Please be careful if they tell you this guy has had gouty arthritis before several times. Do you need to consider septic arthritis now? Yes. We always do joint aspiration even in people that had history of gouty arthritis before, because now they could have septic arthritis. They're sexually active and they have septic arthritis now. In septic arthritis, because the inflammation is so intense, it's probably the most inflammatory of all arthropathies, joint destruction occurs rapidly, usually in a matter of days sometimes. So if you miss septic arthritis and you send that patient home from the emergency room, that guy comes back a week later, 10 days later, they have joint erosion and a destroyed joint if you miss that. We said the most common form of septic arthritis is gonococcal arthritis. About 70% of cases in under 40 years of age. Women seem to be at higher risk in these cases, and especially if they're menstruating or they're pregnant, they seem to be at a higher risk. Non-gonococcal arthritis is usually Staph aureus, and I told you already about this case that we just talked about. They usually have pre-existing joint destruction, like from rheumatoid arthritis or osteoarthritis. The diagnosis is made through arthrocentesis, where we show white cell count of over 50,000 in the joint aspirate. That's diagnostic. Please remember, I told you already, that the cultures and the gram stain are usually negative. Remember, we get the 3 C's and the gram stain from the arthrocentesis. The 3 C's are the cell count, the crystals, right, and the cultures. And then we get the gram stain. Those are the only 4 things we get. But in septic arthritis, even it's infective, but the gram stain and the culture is usually negative because we don't have a high load of infection there. It's a low load, so we don't usually isolate the bacteria. GC is the one that's notorious for this. We only find it in maybe about 20% of cases. Staph aureus and the gram-negative bugs, they're higher, maybe 30–40%, but more commonly, the gram stain and the cultures are both negative. So the only way that you're going to make the diagnosis on this is the white cells are going to be above 50,000, and you're not going to find any crystals there. No crystals, no negative birefringent, needle-like crystals, no rhomboid crystals, nothing. So that's the way you make the diagnosis. The treatment is ceftriaxone. In young people where GC is the case most of the time, we use ceftriaxone. If we're thinking about non-GC, especially in older patients with pre-existing joint disease, we have to add some kind of anti-staphylococcal medication to that, usually vancomycin, because now we have a lot of methicillin-resistant staph, especially in people that have gone into hospitals, offices, and stuff like that. Those are the people that are colonized with methicillin-resistant staph, and we have to use vancomycin in those patients. Usually that's the drug of choice. So combination of vancomycin and ceftriaxone. Usually the young patients, when we're not worried about methicillin-resistant staph, we could probably go with just ceftriaxone, but in everybody else we have to use a combination of vancomycin and ceftriaxone until we find out what the bug is or we sort things out. And that's the end of our septic arthritis section.